Thank you very much. I'm really looking forward to it, and thank Kevin and Brian for including me in this program. So I would like to just talk about ligament injury and how we're looking at to treat it. As you know, this is a very common issue for all of us in this field. We're talking about about 300,000 injuries to MCL and ACL. So of course, for ACL, let me just focus on this today. Is of course the gold standard is reconstruction, hamstring, patellar tendon, and now a quadricep tendon as well. So we spent many years in the laboratory trying to study, just looking at all these variables that you can think of plus more. And we tested a whole bunch of human cadaveric knees as about 25 years. Basically, you can see that you can look at all the graft choices, tunnel, tension, motion, interaction with meniscus and cartilage, and what happened to muscle forces. All these, we're trying to give some quantitative data to improve ACL reconstruction so that we can approximate the behavior and function of the native ACL. So let's look at what's going on. So if you look at the literature, about 3,000 papers are published in any 10-year period since about 30 years ago. And about 90% of papers are involving techniques and complications, including OA. So reconstruction basically is not able to reproduce not only the complex anatomy, but more the property as well as functional ACL. So it is still a huge challenge in orthopedic sports medicine. So let's think back about 40 years ago, the orthopedic field has a sort of a biological revolution. And when gene therapy, human genome, molecular biology has made great advances. And so there's a lot of procedures, methods on tissue engineering, stem cell, and more recently, proteomics. And certainly in 15 minutes, I cannot cover all of them. So I'm just going to choose one or two areas, and hopefully we have a couple of take-home messages. I like to talk about ACL healing because my good friend, Dr. Stedman, he actually have done this microfracture study more than 20 years ago. He used them out and generate healing response for especially proximal femoral tear of the ACL. He encouraged hematoma, bring in reparative cells, and his clinical study for patients over 40 years old, about 4 years of follow-up, have very, very good results. So this is a very good stimulant for us to look into these, revisiting the healing of the ACL. And Martha Murray and Bruce Fleming, they have done PRP study, but recently they published a very nice study on bioactive scaffolds using a porcine model. And they look at it 12 months, you can see that the ACL can heal. And the tensile strength is, they said, is about equivalent, improve over the untreated group here, and it's comparable to ACL reconstruction. The level of OA is significantly improved. This is untreated. This is treated with bioscaffold. But there is hypertrophy of the healing tissue compared to the normal ACL. So in our center for about 25, 30 years, we look at biological augmentation, basically the triad of scaffolds, growth factors, and cells. But we actually came up with the extracellular matrix bioscaffold because of it has a scaffolding, as well as it has the growth factors and cytokine that we needed to heal the ACL. So here's what we did in a goat model. We have a thin layer, 200 micrometers thick of ECM SIS sheet, and we deliver it with gel form because it's too flimsy to do it surgically. We cut the ACL, drill a couple of small tunnels so the sutures could pass. And then we also make hydrogels of the same scaffold. And after we wrap the scaffold around the injured site, and we can inject the hydrogels. And so it's a combination. At 12 weeks, we find the ACL actually healed pretty well with aligned collagen fibers and spindle-shaped fibroblasts. And the exciting part is it acts as sort of a new synovium to protect the healing tissue from the synovial fluid. And tensile properties showed that the stiffness is about 48% of the normal ACL, and ultimately is comparable to ACL reconstruction in the goat model in several studies. So ACL could heal with biological augmentation with just small amount of tissue, a small amount of suture repair. But if we carry the same study to 26 weeks, about half year, then we find out that the location of failure changes. At 12 weeks, it failed where we originally transect the ACL. But at 26 weeks, it fails at the insertion site. And that is because the tissue had matured, the healing tissue had matured to pretty much densely packed collagen matrix. So it's no longer the weakest link. Secondly, because the ACL healing is very slow, then there was disuse atrophy, sort of like immobilization study that we did years ago, that the weakest link now is actually the attachment site. So it begs a new research question, is whether we can do some mechanical augmentation by adding a device that could actually load both ends of insertion sites while the ACL is healing. And if we could do that, it could prevent deterioration of the attachment site. And it also could provide stability to facilitate joint function so joints can move during that period healing while the ACL is healing and is protected. So it came up with a magnesium ring device for ACL healing. And there's schematically, there's a cartoon that magnesium is a biodegradable, bioresorbable metallic material. And you have a cut ACL, you have a little ring that you make and do very tiny holes for suture purposes. The yellow suture is what we call the repair suture, and the orange suture is the fixation suture. And we add the ECM bioscaffold, and basically looking at initially, they were sustaining all the loads. Then it degrades, the ring and the ECM scaffold degrade as the tissue is healed. So you have controlled degradation replaced by healing tissue. You end up with a healed ACL. That is really our concept. So surgically, this is what you do. You can see that the ring is over the transected ACL. We have the yellow suture that is a repair suture to repair, support the healing site. And then we have the fixation suture, so the whole thing is tied together through the small bone tunnels. And also, once it's all done, we inject hydrogels into the healing site. And the result is pretty exciting if you look at the healing ACL at 12 weeks with these mechanical augmentation to biological augmentation. The ACL is continuous, opaque tissue with very well-aligned collagen. There was no hypertrophy, and the ring has begun to degrade to remnants, no cytotoxicity, and the tensile strength is improved with adding the ring. And what about long term? We carried the study to 26 weeks. Now you have continuous improvement. The healing tissue is even more mature, and the ring degrade completely and resolved. And the strength increased about 35% more over that same model at 12 weeks. And it is now 50% higher than ACL reconstruction at 12 weeks. Failure mode now is back to where the ACL was transected. That means the attachment sites, insertion site to femur and tibia are preserved. So it is a sort of a success with mechanical augmentation. So the hypothesis, therefore, is successfully tested. We use biological augmentation to stimulate and accelerate the healing process, and we use mechanical augmentation to restore stability of the joint, partially load the insertion site as the healing is taking place. So these two augmentations work together in synergy, and we have a very, very stronger healing ACL. So how are we going to take these to the clinical arena? So we did some finite element or mathematical model, and we used the GOAT data to find out what the stresses are in the ACL during this healing process, and use that as the criteria to design device for human ACL. And we had to improve our SWIPE device design, and so the surgical procedure is simplified, and it's not only that, we can use the model to customize our design for patient specific and develop arthroscopic technique for implantation. So it is basically to regenerate rather than reconstruct. Healing and regeneration could be then an additional choice for treatment of ACL injuries. But we really should talk about precision medicine because we need to generate big data. Like this morning, earlier, we talked about this Wall Street investor. Everybody has their own preference. But if you have a big data, then you maybe design patient-specific treatment. And that's what we think the mathematical analysis can help. And also, the same thing with evaluation of functional outcome. We develop mathematical models, musculoskeletal module for individual patients with their knee joints. For example, we can then look at this validated model to simulate, to predict dynamics of the joints, ligaments, muscles during in vivo activities. So basically, my message today, rather than talk about all these biological, I couldn't do it in 15 minutes, but I would like to have take-home messages. The biomechanics and bioengineering is really the bridge between biology and clinical medicine. And that's why just recently, this year, my friend, Dr. Chan, and I have published a book called Frontiers in Orthopedic Biomechanics. And I hope that's a good read for you. And with that, I thank you very much for the opportunity to share some of very limited part of what we've been doing, but still very challenging. Thank you so much.